My name is Professor Rachel McKendry and I am the Director of our EPSRC Digital Health Hub for Antimicrobial Resistance. We're bringing together an outstanding interdisciplinary team to develop digital technologies to tackle the enormous challenge of antimicrobial resistance across humans, animals and the environment through a One Health approach. The World Health Organization has declared antimicrobial resistance a top 10 global public health threat facing humanity. Antimicrobials underpin modern medicine and play a vital role in treating infectious diseases and prevention. They're also really essential for many medical procedures, including caesarean sections, hip replacements, cancer treatments. However, in recent years, the pipeline of new antimicrobials has dried to a trickle. Moreover, microorganisms that once were treatable with frontline antimicrobials are becoming increasingly difficult to treat. There's growing recognition of the importance of a One Health approach, given that a third of all UK antibiotics are given to animals, and yet the interconnectedness of antimicrobial resistance in animals, humans and the environment is really poorly understood, and many of those data sets remain in silos. Moreover, there's an urgent need to improve the stewardship of the precious antibiotics we still have to ensure they remain effective for future generations. So we are building the UK's first digital health hub for antimicrobial resistance to tackle these challenges. We will develop a systems-level perspective of needs by working with a really broad range of stakeholders. We will grow new skills and capacities to develop future leaders. We'll develop research exemplars through our Grand Challenge programme and seed new cross-sector collaborations with our partnership fund. And we'll aim to maximise impact and engagement for antimicrobial resistance.
The lack of rapid tests and tools hinders decision-making and antimicrobial prescribing. And where we have current tests, these could provide more timely interventions, but often lack of data capture for rapid tests increases the risks of both false positives and negatives and also of data loss. We have broader challenges, which include a lack of public awareness of AMR, digital interventions that often do not prioritise user-led design and are not grounded in behaviour change. There is also a disconnect between early-stage research and AMR needs, and little understanding of how best digital technologies can be commercialised, regulated and integrated into health systems and patient pathways.
Our training programme aims to grow skills, capacity, knowledge sharing and entrepreneurship in digital health for AMR. Over the next 3 years, we'll be providing opportunities to deliver a hybrid learning approach, combining in-person lectures, workshops and seminars with digital learning tools to ensure learning and development reach the widest possible pool of participants.
Our Grand Challenge research programme is structured around two key themes: antimicrobial surveillance and stewardship. Let's take a closer look.
I am under the Surveillance Grand Challenge, where we will lay the foundations of a trusted research environment for One Health AMR with our partners UK Centre for Ecology and Hydrology, UK HSA, UCL and PathSafe, which is pathogen surveillance in agriculture, food and environment.
In addition to looking at trusted research environments, which are important, you're bringing the data together, it's also important to share that data. And so we're also going to be looking at public health data dashboards and decision-making tools to inform national AMR strategy and to better understand the drivers of prescribing and also the impact of demographics and inequalities. This will inform multivariate epidemiology and machine learning for nowcasting and forecasting and monitor the effectiveness of interventions. We will work with partners to identify target product profiles, including key data sets, quality, privacy, security and ethical considerations, working with the UKHSA, the Welsh Government, Public Health Wales and PathSafe, who are developing the national surveillance platform linking agriculture, food and the environment with the Food Standards Agency.
We're leading one of the work packages on the use of wastewater-based epidemiology for the tracing and tracking of antimicrobial resistance genes. We're combining that with a range of near-source sensors, and the idea is that we can track these genes in wastewater. So, people go to the toilet, they shed antimicrobial resistance genes into the wastewater sewage system, which we can then measure at the wastewater treatment plant by taking samples and analysing them. We're collecting lots of data, which includes about 384 antimicrobial resistance genes, from 47 sites across Wales and including 7 hospitals, so we can look at antimicrobial resistance in the hospital. And the national programme is sponsored by Welsh Government, so we're working with others to look at the use of this data and whether we can dashboard it, how we integrate it together in a sort of an agile, iterative approach, and then working with the key stakeholders such as Welsh Government and Public Health Wales to be able to better understand and predict where antimicrobial resistance is appearing in the environment and also where it's flowing out into our oceans and seas.
Within the Surveillance Grand Challenge, we'll explore the use of online data to estimate and predict antimicrobial usage. Building on prior work using search queries for flu and COVID-19, which have been adopted by UK HSA for national surveillance, here we will explore how weekly and monthly antimicrobial consumption can be estimated based on aggregate web search activity provided by Google Health Trends.
My project is called Samurai, and it's all about trying to tackle the problem of antibiotic overuse, which we know drives antimicrobial resistance. So in hospital, around 1/3 of patients are taking antibiotics at any point in time, but we know that not all of those patients need those antibiotics. And so Samurai is all about using data and AI to help us find those patients who would benefit from stopping early so that we can reduce their exposure to antibiotics and then in turn reduce the burden of antimicrobial resistance.
We're very excited about our work package in the Digital AMR Hub together with Ed Manley, my colleague, Professor of Urban Analytics at Leeds University. We seek to engineer a digital health decision support tool for AMR at UCLH. We want to build on our success in SAFER, our project on healthcare worker risk of COVID-19, where we recruited more than 900 healthcare workers at UCLH only, where we linked virus genomic sequencing data with spatial movement of healthcare workers and behavioral data into a decision support tool. And we want to replicate this success now moving to AMR, so bacteria that develop resistance and can transmit in our healthcare setting like E. coli, Pseudomonas, Klebsiella, and that can be really consequential for our very vulnerable patients.
Our project is looking to develop apps and machine learning for rapid tests for antimicrobial resistance. During the pandemic, millions of low-cost rapid lateral flow tests were used. And looking to the future, these very simple test formats have the potential to transform diagnostic infection testing more broadly and to improve antibiotic prescribing. However, they typically rely on a very subjective visual interpretation of a test line with no automated digital capture. So here we're looking to develop a smartphone app to capture, classify and connect lateral flow test results into electronic patient records, working with end users and also behavioural scientists to create a very user-friendly interface.
We're going to be exploring the use of a machine learning workflow based on Bayesian optimization for design of experiments. And what that's going to enable us to do is to really accelerate the development of rapid tests for emerging AMR threats. And that's really important because we can potentially now, with this new approach, be able to detect them within weeks as opposed to typically months or years.
My role in the Hub will be to provide cross-cutting behavioural science input into the 3 Grand Challenge exemplar projects. We will be applying behavioural science and mixed methods to explore what people think about these new digital technologies, so how acceptable they are, and crucially, what are the barriers and enablers to actually using these digital health tools in practice. And we will then use this information to co-design interventions to improve the tools themselves and increase their acceptability, but importantly also support implementation and practice change.